it's time for us to get going to our next talk. So I like to be quite casual if that hasn't already been noticed. So I'm not going to do the fancy introductions. I'm going to have a little chat. So we have Jessica
Yeah.
and Dr. Dan. Wonderful. Tell us about yourself, Jessica. What do you do?
So I'm going to slip to this side just so that I don't miss it out.
Sure.
So I head up the product design and research team at Etc. Health, which is part of the BT group. Etc. is an incubation hub looking at new products and services in different sectors, health being one of them. We've also got teams looking at fintech, electrical vehicles and drones. And myself and Dan used to work together at a startup called Push Doctor previously that was around telehealth. And that's how we kind of knew each other. And then a lot of us from Push Doctor came over to Etc. Health. So that's how that relationship sort of began.
Wonderful. Yeah. Here you go. Here's a mic.
I think I'm mic'd up.
You're mic'd up even better. So yeah, tell us about yourself.
Hi guys, so Dan Bunstone. I'm a doctor, GP by trade. I've got a surgery in Chapelford, which is in Warrington, northwest of England, Cheshire, Merseyside, for those people who know it. I've been a GP for longer than I remember now, but it's an interesting job. I was Chief Medical Officer at Push Doctor with Jess before joining BT in the role I do now as Health Strategy Consultant. So also deeply involved in NHS still, so doing NHS and GP work, then also, of course, working for BT too. So it's a bit of an interesting dual role because I'm able to do a lot of things inside and for the NHS, but of course, while working for BT.
Wonderful. Well, I'm really looking forward to your talk. What's it entitled?
So reimagine people's relationship with health by taking a digital preventative approach. And it's basically about the digital hypertension remote care service that we set up, designed, built, launched, and of this month scaled across the whole of Warrington. So we're just going to talk about the journey through that. Quite a lot of numbers in there as well, some clinical numbers, some patient stories.
Yeah.
So we're just going to talk about our experience going through.
All right then. So hand over to Jessica and Dan. One quick thing though, it's got this pop-up saying about turn up your volume. So if you move over to the right-hand screen, then you should see the mouse pointer in a moment.
Oh, on this one. I got you.
There we go.
Dual screens.
Right, let's give them a round of applause. Warm them up. Thank you.
Great. So when we started 2 years ago, we'd obviously come from the primary care space, and we kind of wanted to understand the other different care settings that were there, because we know that patients obviously touch all these different services, and we really started looking at the big, large problems that were coming out at the time, with obviously staffing shortage being the key one in the middle. That is not just a problem in the UK, but it's also a problem globally. And one of the first ones that we really started to delve deeper into was the fact that 40% of adults are living with a long-term condition. This is in the UK, and they're actually using quite a large volume of the healthcare system. And at the time, we mapped this to community care because there had been like a huge spike in virtual wards and remote monitoring due to COVID. So we really wanted to understand this space, like how could we innovate in it? What could we impact? What could we bring as Etc. Health to this? So we went on quite a bit of a journey. We luckily had quite a lot of connections in BT, and also through Dan's connections at Warrington. You can see us there in a selfie at Warrington Hospital. And we went around and we met lots of different virtual ward teams. And this gave us a really big insight into kind of how they were admitting patients, how they were monitoring them, and also the admin that was behind that. So it gave us a real big insight. And for me also, going into hospitals and seeing that environment was really important as a designer, sitting with my Mac in a kind of really nice office. I don't really see that side, and I actually got to see that, and it was really, really important for me and really important for the team as well to gain an understanding of that space. It also gave us lots of opportunity to speak with different types of clinicians and get their opinion on how they thought virtual wards were running and how that was impacting them and what their perspective was on that space. And also listening to patients. So we interviewed quite a few patients, mainly with respiratory conditions. So this was quite early on, but one kind of avenue that we looked into was Facebook groups. And this was really interesting because people were sharing so much information on these Facebook groups. I was so shocked at it, but it was so nice, the communities that had been built there, like people looking for advice and guidance on their long-term condition. Like it gave like a really big insight into, like it was maybe a relaxed way for people to kind of share and tell their story. And then why I've got Boris on there is because a lot of the NHS case studies that we were looking at were all related to COVID. And obviously at this point, COVID had kind of started to die down, and there wasn't as many people having it so severely that needed to be put onto these virtual wards. So there was like kind of other conditions that we were looking at. So virtual wards were great for that time, and definitely for COVID. It provided like personalized care. I think one thing for staff, it also gave them a different avenue, maybe like staff that had been burnt out. It was a different way for them to care for patients. And also there was big funding pot. I think Rishi wanted to put 250 million. Have I got that right?
Yeah, those big numbers.
Yeah. So obviously as a business for us, that was like, great. There's, some funding there as well. But there were also lots of challenges. So we saw that a lot of these virtual wards were actually underutilized. So they could only care for about 30 patients at a time. But it was really kind of a disconnect between the community care team running it and the hospital wards. So the hospital wards didn't know how to refer into the service. They were also maybe not fearful, but there was also a risk around, stepping down patients that were quite complex. One case study said that patients on the virtual wards had up to 4 comorbidities and were on 6 different types of medications. So these were really complex patients. And also what we noticed was quite low tech adoption. So the virtual wards that were running, like patients were taking their readings, writing them down on a piece of paper, and then either calling up, like the clinicians were calling them up. So the technology was there, but it wasn't being used in maybe the way that it had initially been designed. So those are the problems. And we were like, how can we make an impact in this space and, overcome these challenges that we saw? So we looked to Desmond.
Yeah, quite. So there's a very interesting quote from Desmond Tutu that basically, well, it's up there, I won't try and destroy it, but talks about not just necessarily dealing with what's happening now, but looking for the root of the problem. Don't just pull people out of the river, try and work out why they are falling in the first place. That resonates really well. Actually, depending if you're based inside the UK NHS health system, NHS is focused a lot on really helping you when you've got a disease, but not necessarily in stopping you get the disease. I will pick cholesterol and blood pressure, and being a white male, I'm a GP, so I wouldn't, but I probably wouldn't see my GP. In my life, I'll go when I'm 0 and I find immunisations and go with mum and me sore throat and me mumps and me undescended testicles or whatever the hell I go to my GP with. After 15, there's a gap up until about 45 or 50. And you talked about this earlier on, where I don't touch healthcare again. Massive assumption here I'm about to make, so please bear with me. Women tend to a bit more assumption, being on the pill, getting pregnant, those sort of things. As I said, assumptions, but that's a massive generalization. Men don't always. The basic principle, though, is that we don't go and see our GP, we don't go and see our healthcare professionals. That leaves a gap. So the next time I do turn up is with chest pain or angina or raised cholesterol, or worse still, a heart attack or stroke. That's why we looked at this whole point. What we're looking to do is left shift. The NHS described left shift as moving from hospital care to GP care. Well, we're going super left shift. We're going even further left, where actually you don't need the hospital discrete intervention. You actually probably and hopefully don't even need the GP intervention. It's about getting you and helping you before you become unwell, treating you early. So that simple high blood pressure, that simple high cholesterol doesn't become a complicated and disastrous stroke or heart attack or dementia or renal failure. We want to get you really early. I guess slightly depressingly, life, the nature of the beast, is that, of course, we will deteriorate over time. We're born, we're hopefully pretty healthy. And for most of us, we can hope to live to 80, but over that period of time, our health will gradually deteriorate and we'll become iller and frailer up until the point where we meet the Almighty. What I would suggest most people would want to do is increase their lifespan, for sure, so live longer, but also their health span too. So what you want to do is have 79 really healthy years, and you will probably tolerate 1 year of not feeling great, because, all right, that's the end of your road, and that's what life becomes. So for us, it's all about health span. There's a whole host of practical reasons for that. Top line talks about cost. I work in NHS. We don't talk about cost, but of course you hear that. You will read the Daily Mail and you will read the Times or whatever papers, and they will talk about NHS being underfunded. Nobody really fully talks about cost, though. Just forgetting cost to the human individual for 1 second. If you're unwell and have to go to hospital, the minimum cost of that to society for you is about £400 a day. Seeing your GP costs about £35 per consultation. Actually, if we can get you treated much, much further up that scale, give you lifestyle advice, get you on an app, get you treated, not enabling you the power to deal with your own blood pressure and cholesterol, then all the better. A lot of it's around democratizing data too, so making things accessible. Agatha around the previous talk talked about not being able to access things. Many of you will be wearing smart watches and tracking data. Some of you probably even represent organizations that design and create them. Unless you're a specialist or that app really helps you, a lot of that data you've got, like your VO2 max that's on your Garmin, massively useful tool. I won't put anybody on the spot, but do you know what that actually means? Self-reflective question. There's a shed load of data you can get from your wearable, but how do you then translate that into something useful, something you can use? What lifestyle changes do you make when you've got a low VO2 max? You know it's there, but what happens next? That's what we're going to get to. Thanks, Jess. I'll continue my theme of being depressive and frailty and death. Broadly in life, there are 4 things that are going to get you, the 4 horsemen, as they're called. Heart disease, which we know about, heart attack and stroke, of course, cancer, big nasty, neurodegenerative disease, things like dementia, and of course, type 2 diabetes, massively increasing because of poor diets and weight gain, etc. Figures on the bottom line are really significant for me. 6 million people in the UK have high blood pressure and don't even know. So the first time they go to see their doctor or they arrive at hospital is with a heart attack or stroke that is often fatal. So the first presenting complaint of blood pressure is death. 25% of all deaths are caused by cardiovascular disease. And of course, the cost to the healthcare, as I talked about before, is around £9 billion annually. Massive. That forgets the human cost. And of course, every 5 minutes, somebody's admitted to hospital with a heart attack or stroke. There are real things we can do about that and the real ways we can step in. And I think we've got a project here that's really helped to do that.
So now we had our direction. We knew that we weren't going to get involved in the virtual ward space. We were going to go further upstream and go into the preventative primary prevention space, which is what we termed it, which is, I mean, yeah, prevention is a term anyway. But so what we did is, as a group, so this is really key with the co-creation. So Dan, obviously there, we've got some photos of us. So we knew that technology alone wasn't going to just solve this problem. We actually needed to own everything. We needed to build the technology, but we needed to map out the processes and really understand the protocols that the clinicians were going to need to use, and that the patient journey, like how that was going to work with the patient journey. And we also needed to build the workforce and understand what people and what those roles were going to be. And we had quite a lot of sessions like this, like really trying to understand like what this program might be, how we might get patients onboarded, how we might monitor people. And this kind of all came out in a document, like a service blueprint that we could then share and, you know, try and get everybody on board. And these are the 3 roles that we used. And once we knew the type of clinicians that would form the the workforce and the clinical protocols and processes in place. This allowed us to understand the different stages of the journey and also the different touch points between each of the users and the jobs that they would need to do in order to create this service. This is a very high level journey of what it actually looked like. It was in mural with lots of boxes and arrows, but this is just a visual representation of it. And to ensure that we had a full understanding of each user type, we went back to research and we interviewed around 15 patients with hypertension. And this gave us like a real understanding of what their experience had been, like had they presented at the GP, and and then they kind of had an annual review, and that had been it. And they kind of hadn't really, a lot of patients that we spoke to hadn't really thought about it past that. In fact, I found out my mum had had hypertension since she was 49 and she's now 65, and she was on medication. I was like, oh my God. And she actually became one of the people we interviewed. And I was like, then I started freaking out with all this information. I was like, are you okay? Take your blood pressure, because she was, and she was at the time going through kind of like having her medication optimized. So it was quite interesting because it became quite personal to me. And then what we found out is that actually most of the people in our team, their parents had high blood pressure, and we started seeing this. And then actually 2 people in our team have been diagnosed with blood pressure from us starting to delve into this space, and they're now like making lifestyle changes, and they're on medication as well. So those interviews were like so important for us to really understand the patient and what they were going through. And it was great because we had that focus of cardiovascular health. We also interviewed healthcare assistants and advanced nurse practitioners that were practicing in the community and in the primary care space. And this was trying to understand what their kind of perception was of like hypertensive patients, how they were working, and what their thoughts were of remote care. Like some were really receptive to it and really wanted to kind of learn more about the technology and work in that way. And they thought it was like a good way, if they kind of been a bit burnt out through COVID, like that, it was quite interesting. And we did some really like early concepts in front of these of like what the platform might look like, and a little bit of like usability testing. So this research really helped us define what our flow would be. And it also gave us like a backlog of features that we could build for the technology platforms. So developing the technology, this is not the MVP that we launched with, but I couldn't bring myself to put the MVP up as a designer. But like most of the remote care platforms, we had a patient app and a clinician platform. And the first kind of features that we launched with was ensuring that we could admit patients and that they could be sent a link to activate their account, and that they could link up their vitals to be collected and monitored by clinicians. So that was kind of like the base feature that we used that. But what we did know is that clinicians were using, so the AMPs and the HCAs were using a spreadsheet to manage the other aspects of the service, which they termed the spreadsheet of doom. And there was probably more, I think there was more than one spreadsheet of doom as well. I looked at a bit of capacity management in hospitals, and I knew that like they were using spreadsheets in hospitals as well. So it is a tool that can be used to get something started, but obviously so many limitations, so many like the loss of data as well, and inefficiencies. So we knew this was a really good opportunity for us to kind of like build on that technology. So the real key objective for the squad managing the clinician platform was to create features and flows that eliminated the usage of this spreadsheet. And I can actually successfully say that the spreadsheet of doom is no more. It's gone. But yeah, so this is where we were with the technology platform. So now we had our technology, we've got our service blueprint, we've got our technology, we need to get the patients on board. So the first round of patients we did in person, and our operations lead, Lauren, she has such a calming, like lovely nature and tone about her. She invited 12 of the patients in and onboarded them. They loved it, but this took 40 minutes. So we were like, this is not scalable. But we actually got loads of really good insights and learning. So we knew how we could, we knew how the messaging around the program that we had to say. We knew what FAQs might come up. So this led us on to moving on to phone, and we actually, Lauren, the operations lead, the product manager, and myself, we wrote a call script for the HCAs. So this allowed them, really step by step into to be able to introduce the service. And we also mapped out an onboarding guide. So screenshot every single moment in the app that allowed them to help talk people through onboarding the patients. And this worked quite well. And they actually did like 851 calls. But as the service started to grow and the HCAs had other roles that they needed to do, it wasn't scalable again. So we moved to SMS invite. And this gave us a massive reach. So you can see we had a bit of like, what do I call it? Hockey stick moment?
Hockey stick,
yeah. And so we got our reach. We actually had a better conversion rate with phone calls, but the SMS gave us the reach, and then we could use the phone calls as like a follow-up. And this allowed us to onboard 1,090 patients, probably in the space of around 3 or 4 months.
Yeah, it was 2 or 3 months.
So quite quick for a new service. Maybe not for a digital app, but we weren't using sort of like marketing. It was very kind of like a person-to-person approach. But that meant that we also had to ship 657 blood pressure monitors. And in the theme and in the spirit of being a startup, even though we're a startup in a corporate, we didn't have the kind of operational process in place at the time. So we actually boxed and labeled around about 400 to 500 blood pressure monitors. We had like a packing. The product manager was actually so speedy, Will. Like he was like packing away, like he was amazing. And this meant that the patients that had been onboarded who didn't have a blood pressure monitor could get that really quickly. And then actually, as we started to scale, and we've got something in place now that could do this at a larger scale. And also we had that allowed us to get 14,000 readings. So how did we learn and iterate? So we've got our kind of platform running, we've got the service running, we've got patients onboarded, but we still wanted to make sure that we were learning. And this first one, the bi-weekly clinician sessions, so we had a remote care team of about 4, so 2 HCAs and 2 AMPs. So we would meet with them every 2 weeks, and these were so carefully curated. We had 1 hour with them, and we tried to get everything we could. And the product design and product manager really ran these really tightly. And we addressed feedback on kind of platform developments for both the clinician platform, but they were also getting information from the patients that they were speaking to. So that allowed us to kind of build up some improvements that we needed to make. We also ran kind of ideation sessions, so what features they wanted to add, what they were looking for. And then we also did some prototype feedback as well. So from the ideas, the product designer would go off, build a prototype, and then bring it back for the next session that they could critique and review. And it wasn't maybe so, and then we were doing usability testing on this as well as that, but these were the people using the product at the time, and that was amazing. Those bi-weekly clinician sessions. And that allowed us to get to the platform to where it is now. We also looked at service data and patient surveys. So we ran a survey at the end. One journey that was really crucial that we needed to get right was patients being able to submit accurate blood pressure readings. And as these have been shipped to their home, we couldn't actually see, were the instructions right that we'd created? Were they using the blood pressure monitor? And we're lucky enough at BT, this is where it gets in really handy, working for a big corporate as well, that we have 2 labs, one set up in Birmingham, one set up in London. And so we invited, we did 2 sessions, both with 5 patients each time, to come in and set up the app, use the app, and take their blood pressure, so we could see how they were using it. We weren't just using data, and this gave us some real insight into the instructions, and we've actually redesigned that journey for a more intuitive one that allows people to submit their blood pressure readings. Finally, which really links in with the stories, is in-person patient interviews. So we contacted some of the patients that have been on the pilot, and we asked them if we could meet them face to face. And actually, we asked them if they wanted to do this at the GP surgery or in their home. And 2 of the patients wanted to do it in their home. And it was actually a bit of like a personal highlight for me, because I'd kind of always wanted to kind of really get that context of like a user. Like, there's nothing more personal than going into someone's like space. And these were 2 of the stories that I really wanted to share. Like Sarah, she actually met us, and these are actually anonymous names, but the stories are true. She met us in the GP practice, and her story was amazing, really. So she was a civil service worker and worked really kind of like long shifts in quite high pressure situations. And she'd started to get symptoms of menopause, and she'd been contacting the GP a lot, and she felt like she was becoming a bit of a burden. And actually, this service made her feel like it was really convenient. So it fit in with her job. So in the evenings, she would finish her shift. She would take 10 minutes in the back room. She would go and take her blood pressure. She would submit those readings. And then if needed, she would send the remote care team an email. And she said that it made her feel like she wasn't a burden, like she still felt like she was being supported, but that she wasn't like hammering the phone all the time. And that for me was and she was an amazing like research participant, because she just spoke for the whole hour, and like we were just like sat there, like, you know, when you take in all the information, you're like, oh, this is so good. So she was amazing, Sarah. And then Paula, she invited us into her house, and that is one of her cats there. And actually, she was quite a high risk patient, and she'd really been battling with her high blood pressure. And actually, the service she had a blood pressure monitor, but had been in a cupboard, and this service had made her kind of like almost like start re-monitoring her blood pressure. And actually, at one point, it was really quite significantly high. And she actually felt as though the service had saved her life. And obviously, that was amazing to hear, and she was lovely and just so nice for inviting us into her home. And we did actually get to a point where she is now on like suitable medication. And one of the things, the AMP had told her to eat avocado on toast every morning, and that is what she now did, is eat avocado on toast every morning, from some of the lifestyle changes. And that's definitely one thing that we've noticed, along with behaviour change, is a lot of these patients who'd had kind of lifestyle advice given to them is that they would take that one thing, and they would really follow through with it to make those changes, which is really helping us now when we've started to delve into that behaviour change space. So I'm going to pass to Dan now. He's going to talk about some of the clinical impacts that we had.
Thanks, Jess. I think the key bit is, of course, when we design and make something, it's working out what the so what is, what the impact is, how that's changed people's lives. Has it been used? And more than used, has it had an impact in people's lives? I'll talk you through some of these numbers. As Jess said, we admitted about 1,000 patients and treated around 65% of them to target. Why is that important? The 1,000 patients we admitted, we didn't screen and find and treat. These are the patients that previously hadn't been treated to target, had been lost to follow up, and had been sat there with high blood pressure. So it was already, in inverted commas, a difficult audience to address. So having any number there at all would be amazing. 65% is huge. Their blood pressure drop of around 12 points, 12 millimeters mercury, depending on how you look at that. That's significant because it reduces that cohort's risk of heart attack and stroke by about 3%. So 3 people per 100 will not now have a heart attack and stroke because of the intervention, the app, and the correct blood pressure treatments made. That's massive. That's why those big 2 numbers there are huge. 15 heart attacks and 15 strokes prevented over the next 3 years. just from what we've done in a relatively small cohort of people, which feels amazing. I think in healthcare, and there was a question, I think I asked a question before, we create, sorry, there's lots of feedback here. Shall I change mics?
Do you understand?
Shall I move on to that?
If you just move away from the speaker.
Oh, will that help? Is it just simple feedback?
It is a speaker
okay.
behind you, which...
I go here, really mix it up. Look at this. I've got this over here now. Can you still hear me or not? So look at the, oh my God, this feels amazing. I should have stood here before. I feel like some sort of god. 15 heart attacks and strokes. I should have done this before. Like, I'm like the weather girl now with a different screen. It's amazing. The weatherman with a screen, which is huge. I think we create, sorry, back to the point, lots of bad touch points for patients. You said this before. Patients always pick the wrong time to come and see us and at the wrong venue. And what do I mean by that? You get told to come back in a week's time and see how things are. Or, oh God, you've had a cough for 3 weeks. Why didn't you come and see me sooner? There's this tiny little place you can aim for as a patient, and not knowing where things are and being worried and concerned and not knowing what to do. You said embarrassed. Absolutely right. I think people are embarrassed in case they're like, oh, shouldn't bother the doctor. We've created that environment. So something really to be clear about. This, for me, gets rid of that embarrassment and that pestering piece, because of course it creates a service where we reach out to people, we come and get them. It completely changes the relationship. You don't phone me saying, hello, doctor, what's my blood pressure like? We monitor you and then say, actually, Mr. Smith or Paula or Sarah, your blood pressure is not great. Here's what you need to do. Here's how you make things better. We've flipped the relationship, and that's how we've got the numbers we've got. Next slide, please. How we're scaling, I'll make this bit quick. Chapelford's my surgery in Warrington. So we started small, covering a base of around 7,000 patients. We quickly moved into a PCN size, which is a primary care network. You'll be familiar with that. I can talk about that later, but primary care is now melded together where GP surgeries work together, still partners, but they work together. So we moved over to that. We've just finished that project in Wynn, and we're just scaling out now across Warrington, around 250,000 patients doing the same thing. We've got an aspiration to treat around 3,000 patients to target. That will save, hopefully, massive numbers of heart attacks and massive strokes. The NHS is super interested in where we are at the moment. Everybody's talking about prevention, whether it's Fuller or Hewitt or NHS Plan. Nobody's doing it. Nobody's really investing in getting the bridge fixed rather than just picking people out of the river. We're spending all our resources on picking people out of the river and not investing. Aspirationally, we'll then move on to the wider Cheshire Merseyside network. So, of course, Warrington forms a part of that. And we're already in conversation with some of the larger national ICSs. The point of this is to say we start modestly small and you grow and you evolve in a PDSA cycle. The NHS can swallow that because they start with small investments. They get bigger and bigger, and you show your worth. So you're not going saying, I want £10 million, but I'll give you £300 million back in 2 years' time. You're asking for a tenner, and then 10 grand, then 100 grand, then £1 million. And it gets bigger and bigger. You build your successes. Jess?
Great, thanks.
I'm staying here.
Oh, okay. So we just wanted to close with a little something of where we're going in the future. And this is actually more for our early detection audience. So we've got our primary prevention space for scaling that out. We now want to interest people more in that early detection space. And we became a bit obsessed with a doctor called Peter Attia, who wrote a book called Outlive. And I first became a bit obsessed with him when he did Diary of a CEO. And then we all bought the book, and now all of us have bought the book. And he really got us interested in health span. And off the back of that, we've really started looking at how we can kind of move further to the left, but also inspire people to have a look at that health span. So instead of, the dip, like I can see my mum in this 10-year dip between her health span. Like, she's got high blood pressure, she's had any operations, she started to get arthritis. Like, I can see her in that phase, and I'm like, oh, I wish we'd had this however many years earlier, and I could kind of get her more engaged in physical activity, or just even like looking at some of the risks. So this is in development at the moment, and it's still very early days of how we're refining it, but we're looking at giving people a health span potential score. And this takes into account people's lifestyle behaviour, including data from their wearables. It will give them a score, and then it will give them some recommendations to be able to make behavior change in their lifestyle, and also we want to look at the risks that there may be. So that's kind of where we're up to now. We're going to launch that in the next couple of weeks, I think, and start testing it out and seeing how people understand it and start adopting it. And behavior change is definitely something that we're really interested in now.
All done?
Yep, all done.
All done. Give him a round of applause. Yeah, I've had some experience working on projects where you look at how can you assess someone's health to rate it. There's so many subjective things to look at as well as objective ones. But yeah, really, really great talk. So yeah, any questions from the audience? Yeah.
Do I keep hold of it? No.
No, just press.
Hi, I'm Charlie. I'm a management consultant working in the design space in the public sector. My question was around digital adoption from the clinicians' side and whether, like, what challenges you found there. And I asked because my dad is a GP in Greater Manchester, and the way he talks about technology being rolled out is just, it's quite funny when you work on the other side of it. So yeah, I just wondered how you managed that, what the particular challenges are, and yeah, how you handled it.
Yeah, definitely. And we definitely got that. We got quite a split when we were interviewing people. There's probably like 50% that were really interested in technology, and then the other 50% were a bit like, oh no, I kind of know the tools that I've got. And it is probably the same as for patients. It's that kind of like fear of the unknown and not being sure of how to use it. Those clinician sessions were definitely super key. And then I think because they were in first instance, they were using a technology platform that was quite like simple, like with the monitoring, but then they had these spreadsheets. And then as we started to build features in the product that were helping them, so it was creating more efficiencies for them, they started to adopt the technology more, because then they saw the value of kind of moving away from the spreadsheets or maybe even paper-based to those features then being like made on the platform. One thing that we also did is that you said we did, which we learned from a conference like last year, is that every time we had those feedback sessions, we would then kind of go back to them and say, you said this, and so we implemented these features off the back of it. And we also did that with patients. So every time we kind of interview someone, then it shows like the value of like where their research is going. And it's been a really good technique to kind of, show value to why they're spending their time. I mean, obviously we do pay incentives. I really believe in paying for people's time. But also it's nice to know that they're making an impact. So yeah, I suppose it's that co-creation piece, which is really hard to do. And I know the NHS talks about it all the time, but it is really key, because I also think clinicians' brains work in a completely different way. Like we had, I can't remember what the term was, but we had a button that we called it something like exit or clear. It was clear. And it was on a filter, and the clinicians were afraid to press it because it said clear. And they were like, I feel like I'm going to just delete everything. So we had to, like small things like that made us look at even like the language that we were using. So I think the only way is like actually like really getting in front of clinicians, really showing them early days, looking at like nuances, like the language, and just kind of building that rapport between you're building the products, and then being able to use it as well. So hopefully that answered it.
Any other questions? Okay.
Great presentation, well done.
Oh, thank you.
I don't know if you can answer that question.
Hang on, but who are you?
My name is Georgia and I work for Bupa Global as a clinical
okay.
UX designer, the private health insurance. So I don't know if you can answer that question, but your product is super promising, of course. Have you thought about collaboration with other industries like insurance, for example? Because not they, we work with third parties when it comes to patients' data collection. And I think, I was just wondering, what's the scope of your project really?
Yeah, definitely. Like, I think that we're looking like the NHS is one market, and I think it's quite good because it kind of gives you that validation stamp working with the NHS, and it also gives you, that's where patients are going. Initially, obviously they are using private services, insurance services as well, but yeah, it's definitely something, a market. I think at the moment we've kind of in the NHS space, but that is definitely a longer term goal for us. And I think sometimes those relationships maybe take around 18 months to 4 years to kind of come together.
Maybe less so for a health insurer. Like, it takes time. It's a massive organization. But I hear what you're saying, though. It still does take time.
Yeah, I think it's definitely something. I think now that we've proven it a bit more with the NHS, that's definitely, now we can go and we've got the kind of numbers and data off the back of it. But yeah, it would be great to catch up as well to see if there's something. Yeah.
Take one more question.
Hello, my name is Lee Moyer-Vilfker. I'm the Associate Director of Product Design at Memorial Sloan Kettering Cancer Center in New York. Great presentation. Really enjoyed it. And I was wondering if you could talk a little bit more about some of the resistance factors that patients had in getting on the app, potentially data privacy, anything like that you can share?
So the challenges that they had with adopting.
Yeah, with adopting, with signing up, any resistances that they had or skepticism that they had in actually getting on the app.
Did you hear anything from?
There's a slightly anecdotal story where we were getting the BP machines sent through to patients, and the DPD driver took it upon himself to tell everybody he was delivering them to that it was a scam and to send the machines back. So he did us absolutely no favors at all. So we had a load of machines that were turning up back at the surgery. And of course, how that came to light was, of course, a patient phoned my surgery and said, actually, this is what's happening. So that was pretty interesting. I think we got around that because, as Jess alluded to before, the app itself, we spent a lot of time initially with those first 12, where we spent a lot of time working out actually what the barriers are. So that 40-minute per person, it wasn't wasted time. It was, it was by design, wasn't it?
I think actually another barrier that we had that wasn't necessarily patient was actually, like, this was a service as part of the PCN, but it was kind of in the PCN, but they also had their GPs. And then when they were going to their GPs, they could see other people had written in the medical record, and they were like, who is this person? And then the GP would kind of intervene, and then it would be kind of like a bit, so then the patient was really confused. So then patients would come to us and be like, oh, well, I've had my GP and they've said they don't know who this person is. So when we've launched at a larger scale, we've kind of done a lot more communication between the practices to kind of stop that like confusion between things. I mean, we did have a drop-off rate. I think we asked patients to submit like 8 readings over 7 days to allow us to get an average blood pressure reading, or it could be over 4 days. You could do 2 readings a day. And some patients, that was probably the biggest drop-off point, which is another behavior change piece. It is like people remembering to take that. So sometimes if they missed a day, then you would or a couple of days, and they couldn't get the average reading. So they were great on boarding, and they would kind of like be excited about the service, but then remembering to do that piece of that's where, and people kind of getting stuck there. So then the clinicians were like intervening and having to remind them. But that's something that we've built in as a feature in the app now, that we allow them to be able to track it, and then we can nudge them a bit better. So it was a bit more of like a learning curve for us that I think hopefully we've solved with this next thing, but we'll see with the data.
Yeah, time will tell.
Thank you.
Right. Thank you so much for the talk.